You take them every morning without thinking. Maybe you line them up on the counter next to your coffee. Maybe you keep them in one of those plastic pill organizers with the days of the week printed on top. And every single day you swallow them. Because your doctor told you to. Because you trust the system. Because you assume someone was keeping track of whether these medications still made sense for your body at the age you are right now. I need you to hear something today. 4 of the most commonly prescribed medications in the United States were designed, tested, and approved for a version of your body that no longer exists. And the research that should have triggered a serious conversation at your last appointment has been sitting in medical journals for years while your prescription auto-refills without a single question asked. I'm Dr. Kevin Ashford. I've spent years helping patients over 50 navigate exactly this situation, where the pill that helped at 45 is quietly compounding problems at 58. Today, I'm going to walk you through 4 specific medications that I would personally refuse to let anyone in my own family continue taking after the age of 50 without a thorough reassessment. I'll explain what each one does inside your body, why the risk profile shifts as you age, and exactly what to ask your doctor at your next appointment. One of the alternatives I'll share has been available for over a decade, and most patients have never been told it exists. Before I go any further, I need to be absolutely direct about something that could protect your health. Nothing in this video is permission to stop a medication on your own. Stopping certain drugs abruptly can be dangerous, even life-threatening. What I'm giving you today is information and specific questions to bring to your physician. The goal is a better conversation, not a unilateral decision made at your kitchen table. The first medication is one that millions of adults over 50 take every single day for acid reflux, and many of them have been on it for 5, 8, even 12 years, without anyone suggesting they stop. I'm talking about proton pump inhibitors. You probably know them by the names omeprazole, lansoprazole, or the brand names Prilosec and Prevacid. They work by shutting down the tiny acid pumps lining your stomach wall. Less acid means less burning, less damage to the esophagus, less pain after meals. For short-term use, 2 to 8 weeks, the evidence supporting them is solid. For severe reflux, ulcers, or a condition called Barrett's esophagus, they can genuinely change your life. The problem is, what happens when short-term becomes permanent? Your stomach acid is not a design flaw. It breaks down proteins so your intestines can absorb nutrients. It kills bacteria and pathogens in the food you eat. And it triggers the release of digestive enzymes your body depends on. When you suppress that acid for years, the downstream consequences are real. A study published in the Journal of the American Medical Association found that long-term proton pump inhibitor use was associated with a significantly increased risk of hip fractures in adults over 50. Without adequate stomach acid, your body struggles to absorb calcium and magnesium. Your bones quietly lose density while your reflux stays controlled. Patricia was 63 when she came into my office with a wrist fracture from a minor stumble in her driveway. She had been on omeprazole for 9 years. Her bone density scan showed osteopenia that nobody had connected to her medication. There is also growing evidence linking prolonged use to kidney disease, vitamin B12 deficiency, and dangerous intestinal infections. The B12 issue alone deserves attention. Your body needs stomach acid to separate B12 from the protein it is bound to in food. Suppress that acid for years, and levels drift downwards so gradually that nobody notices until the deficiency shows up as numbness in your hands, difficulty concentrating, or fatigue that gets blamed on aging. So what do you do? First, do not stop abruptly. Proton pump inhibitors cause a rebound effect where your stomach produces even more acid if you quit suddenly. Any tapering needs to happen gradually under your doctor's supervision. Second, ask whether an H2 blocker like famotidine might manage your symptoms with fewer long-term risks. Third, Ask whether lifestyle modifications, eating smaller meals, not lying down within 3 hours of eating, elevating the head of your bed, might allow you to reduce or eliminate the medication entirely. The second medication I would challenge for anyone in my family over 50 is one that gets prescribed almost reflexively for sleep. Benzodiazepines. The names include lorazepam, diazepam, temazepam, alprazolam. You might know them as Ativan, Valium, Restoril, Xanax. They work by enhancing the effect of a calming neurotransmitter called GABA in your brain. For acute anxiety, for a medical procedure, for a brief crisis, they have a legitimate place. The issue is that after 50, your liver metabolizes these drugs more slowly. A dose that would clear a 30-year-old's body in 8 hours might still be circulating in a 60-year-old's bloodstream the following afternoon. The American Geriatric Society placed benzodiazepines on the Beers criteria list, which is a catalogue of medications considered potentially inappropriate for older adults. The primary concern is falls. Benzodiazepines impair balance, slow reaction time, and cause dizziness, particularly when you stand up from sitting or lying down. A large study published in the British Medical Journal found that benzodiazepine use was associated with a significantly elevated risk of hip fracture. Separate research has linked long-term use to cognitive decline and an increased risk of dementia. Richard was 57, a retired contractor, physically active. His doctor prescribed lorazepam for insomnia after his wife passed away. 2 years later, he described his thinking as foggy. He was forgetting appointments. His daughter noticed he seemed slower. When we began a supervised taper, the fog lifted over several weeks. He told me it felt like someone had cleaned a dirty windshield he did not know was. There is another dimension that patients rarely hear about. Benzodiazepines create physical dependence surprisingly quickly, sometimes within just a few weeks of daily use. Your brain adapts to the drug and produces less of its own calming chemistry. When you try to stop, anxiety and insomnia come roaring back, often worse than the original symptoms. Many patients interpret that rebound as proof that they need the medication, when in reality, the medication is creating the very problem it was supposed to solve. If you are currently taking a benzodiazepine for sleep, ask your doctor about cognitive behavioral therapy for insomnia, which research consistently shows is more effective than medication for long-term sleep improvement without any of the fall or cognitive risks. The third medication is one of the most widely prescribed drug classes on the planet, and questioning it will surprise people. I'm talking about certain statin medications, specifically at high doses in patients over 50 who have no history of heart attack, stroke, or diagnosed cardiovascular disease. Statins save lives. In patients who have already had a cardiovascular event, the evidence is overwhelming and I would never argue against them. The question is different. If you are over 50, your cholesterol is mildly elevated, you have no history of heart disease, and your doctor put you on a high-dose statin purely for prevention, has anyone revisited that decision in light of your current health and the side effects you may be experiencing? Statins work by blocking an enzyme in your liver that produces cholesterol. Your numbers go down, but cholesterol is not purely a villain. Your body uses it to build cell membranes, produce hormones, and synthesize vitamin D. The most commonly reported side effect is muscle pain, clinically called myalgia. For adults over 50 who are already losing muscle mass through sarcopenia, which is the natural age-related decline in muscle, adding a medication that causes muscle pain can accelerate that decline. The person who was walking 2 miles a day stops because their legs ache. Physical activity decreases, and the overall cardiovascular risk profile gets worse. Research published in the Annals of Internal Medicine has shown that in patients over 75 with no prior cardiovascular events, the benefit of statins for primary prevention becomes less clear, while the risks of muscle damage, diabetes, and drug interactions increase. Some patients also report memory difficulties or mental sluggishness on high-dose statins. The FDA added a warning about cognitive effects to statin labels years ago. For most patients, these effects are reversible when the dose is adjusted. If you are on a statin and experiencing muscle pain, fatigue, or weakness, do not just accept it as aging. Ask your doctor whether your dose could be reduced. Ask whether your individual 10-year cardiovascular risk score actually justifies the medication, or whether dietary changes and exercise could achieve a comparable benefit without the side effects. The fourth medication is prescribed to millions of adults over 50 for pain, and many of them take it daily without realizing how much the risk has shifted since they turned 50. I'm talking about non-steroidal anti-inflammatory drugs taken on a regular basis. The names include ibuprofen, naproxen, and diclofenac. You know them as Advil, Aleve, and Voltaren in its oral form. For occasional use, these medications are generally well tolerated. The danger emerges when occasional becomes daily, and daily stretches into months and years. After 50, your kidneys are filtering blood more slowly. Your stomach lining is thinner. Your cardiovascular system is managing higher baseline pressures. Non-steroidal anti-inflammatory drugs affect all three systems simultaneously by reducing protective compounds called prostaglandins. Think of prostaglandins like the maintenance crew in a building. Nobody notices them when they are working. But the moment they stop showing up, the pipes corrode, the walls crack, and the whole structure deteriorates from the inside. A comprehensive review published in The Lancet found that regular use of these drugs was associated with a meaningful increase in the risk of gastrointestinal bleeding, heart attack, and stroke, with the risks climbing significantly in adults over 50. The bleeding risk is particularly insidious because it can be slow and internal. You feel tired, maybe a little lightheaded, and you attribute it to getting older. Meanwhile, your hemoglobin is quietly dropping. Thomas was 54, taking ibuprofen 3 times a day for chronic knee pain. He came in feeling exhausted and short of breath. His blood work showed he was severely anemic from a slow gastrointestinal bleed he had no idea was happening. He had been buying ibuprofen over the counter and never thought to mention it to his doctor because it was not a prescription. If you are relying on daily non-steroidal anti-inflammatory drugs for pain, ask your doctor about topical diclofenac gel, which delivers medication directly to the joint without the systemic exposure. Ask about physical therapy, and ask whether the underlying cause of your pain has been properly diagnosed, because masking joint pain with daily anti-inflammatory drugs while the joint continues to deteriorate is not a treatment plan. It is a delay. Here is what I want you to do with everything we covered today. Before your next appointment, write down every medication you take, including over-the-counter drugs, and how long you have been taking each one. Then bring 3 questions. First, ask your doctor whether each medication still reflects the best current evidence for someone your age with your specific health profile. Second, ask whether any of your current symptoms, fatigue, muscle pain, brain fog, digestive issues, could be side effects of a medication rather than signs of aging. Third, ask whether a lower dose, a different drug, or a non-medication approach could achieve the same goal with fewer risks. You deserve a medication list that was built for who you are today, not who you were when the prescription was first written. Your body at 50, at 55, at 62 is not the same body that started those prescriptions. It deserves a medical plan that acknowledges that reality. I'm Dr. Kevin Ashford. If someone you care about is taking a handful of medications that haven't been reviewed in years, send them this video. One honest conversation with their doctor could change the trajectory of their health. Take care of yourselves, and I'll see you in the next one.